Now, in order to understand what it is we're assessing, we perhaps just need to refresh ourselves on what the muscle does when it's under stretch and what its kind of subsequent or consequent response is going to be. Now, to that end, what we start off with is we know we've got our kind of muscles, and if we dig inside and we go it down to kind of internal mechanisms, we go down to kind of microscopic levels, you've got a series of sarcomeres. And remember that you've got your sarcomeres both in series and in parallel. And as the sarcomeres shorten, there is, not surprisingly, an increase in the amount of overlap between the actin and myosin filaments. They start to slide past each other. And when we get elongation, so that's the muscle under stretch, the degree of overlap between those filaments, the actin and myosin, starts to decrease. And that's how we get the changes in muscle length. And if we think about what you've got, is you've got the muscles then connected to the joints through ligaments and tendons, but fundamentally it is the change in the overlap between the actin and the myosin filaments that will dictate the degree to which the muscle changes length and the degree to which the joint then articulates. And that is what we're assessing when we're assessing range of motion. If we then get any further stretch to the muscle complex, it can only come through connective tissues. And they also elongate, and they have their ability to change their direction of orientation to that of the developed tension within the muscle. So there has to be a point there where the muscle gets to maximal stretch. You can then get a little bit more of kind of stretch beyond that point, and that is simply where there is a degree of pliability within the ligaments and tendons of the muscle themselves. Now, in order for this to all operate, we have to recognize that there's a point, if we think about it very logically, there's a point beyond which a muscle can't stretch, and there is a point beyond which, therefore, a joint cannot articulate. And the control of that is through what we call proprioception and the role of the proprioceptors. And they are termed as muscle spindles, and they really play a significant role, as we've got here, particularly when the muscle is under the state of elongation. Because as the muscle elongates, so do these spindles. And that should tell you straight away that if they are, in essence, responding to the elongation of the muscle, they must be sensitive to changes in muscle length. And so they understand, and they are, through the process of neural feedback, they are, in essence, monitoring the change in the length within the muscle. And therefore, they're able to determine whether the muscle is at a maximal point of elongation. So they're sensitive to length, but they're also very sensitive to the rate of change in the length of the muscle. So it is these proprioceptors in the shape of these muscle spindles that are there to prevent overstretch, and therefore fundamentally should, not in all instances, of course, because we do get muscle damage, prevent muscle damage, particularly under high velocities of shortening and high tensions within the muscle. Now, additionally, in the tendon, we have two more proprioceptors, and these are sensitive to tension and pressure. So remember that as tension builds up, pressure increases, the pressure within the muscle cell itself. So we have these additional proprioceptors which are imparting that information in terms of, well, how much tension is being built up. Remember, as we change the length of the muscle, we change the tension. We have the length-tension relationship. So we know there is an optimal relationship between length and tension. It's at around about 2 micrometers. Anything shorter than that, and then what you've in essence got, you've got too much overlap between the actin and myosin filaments, and we in essence don't generate optimal force, and therefore we don't generate optimal tension. If we go beyond that 2 micrometer level, we start to get too little overlap between the actin and myosin filament. They stretch beyond each other, and therefore you don't get the interaction between actin and myosin. Force dissipates, and therefore tension dissipates. And because we have proprioceptors that are sensitive to length, we therefore, not surprisingly, have proprioceptors that are sensitive to tension, because length and tension go together. Pressure is then a function of tension. As the tension builds up in the muscle, so does the pressure, because fundamentally the muscle is squeezing within that space in which it is being asked to elongate or change length. Now, in terms of the muscle itself and the stretch, what we call the kind of the stretch reflex, there are two components to this. Remember, the muscle is going to go under stretch, and then what you in essence get is you get kind of feedback, which is telling through the central nervous system, it's telling where we are in terms of the length, where we are in terms of the tension, where we are in terms of the pressure. And so there is a dynamic response, which is very strong, but that actually deteriorates over the course of the stretch. And there is a static, which remains constant for as long as the muscle is elongated. So we have these kind of two control mechanisms, which are there to control the amount of tension and the amount of length change that we get in the muscle. And remember, this is the key, that we're talking about muscle physiology and muscle mechanics, but fundamentally the change in the length in the muscle, the change in the tension in the muscle, determines fundamentally the degree to which the joint articulates, and therefore will affect the range of motion around that joint. Now, when we think about the articulation of a joint, what we recognize is that there are actually a number of factors which limit the notion of muscle stretch, the ability of the muscle to elongate, and therefore the ability for the joint to articulate. And there are four components here taken from this reference that you can see here in a textbook that I put together on coaching science. They are neurogenic, they're myogenic, they're the joint structures, and they're the periphery. So the neurogenic are those neurological factors. So either through the stretch reflex or kind of voluntary control. These are in essence related to our proprioceptors that we've already been referring to. Then there are the myogenic. Myo is the Latin for muscle. And those are both the active and passive components in the muscle itself. And that is very much dictated by the articulation and the architecture of the muscle. How are those muscle fibers laid? Are they pennate? Are they bipennate? Are they fusiform in terms of their structure? So that determines then that the way in which those sarcomeres lie, both in series and parallel, in terms of it dictates the degree to which we get active stretch within the tissue. Remember that muscle fibers don't all just lie in one uniform direction. We have them which look like, as I say, bipennate and pennate and fusiform kind of articulation. You then have the joint structure itself. Well, that makes a lot of sense, right? Because you've got obviously the ligaments and the tendons. Their job is in essence to be resistive to stretch, but also the joint itself. We know we have different joints. We have ball and socket, for example. You know, a ball and socket joint, the way that operates is very, very different. For example, if you compare that to the joints within the spine, for example. And so the way in which the joint is structured determines the degree to which the joint can articulate, irrespective almost of what the muscle can do. And then finally we have the periphery. So the periphery is kind of everything else. It's things like the tissue, the subcutaneous fat, the skin. All of those dictate what is going on. The best way to think of this is, if you think I don't quite understand this one, well, think about skin. Think about somebody, for example, that's had Botox. And if you see somebody that's had Botox, a lot of Botox, the skin is pulled really tight. And it looks like when they've had that done, that it looks like there is no movement, particularly in the face. In the face, it's not that the muscles aren't moving; it's the fact that the skin is pulled so tight underneath it. It's actually preventing a lot of that kind of natural movement within the muscles. And so the net result is the skin is reducing the degree to which the muscle is under stretch. So why do we assess flexibility and range of motion? You know, what is the rationale for doing this? Well, in many ways, the rationale for this is very similar as it is for most components of fitness, but it is probably the most overlooked parameter in both exercise science and also strength and conditioning. Sports therapists, it's obviously very, very common. It's kind of one of the fundamental measures, but a sports therapist may come at this in a slightly different way. Well, the first reason we do this is maybe in relation to sport is, well, actually, can somebody perform the requisite action with as minimal amount of stress being placed on the muscle tendon unit. Now that could be both in terms of sporting action as you've got here with the cricketer, or it could be in a clinical population group where somebody is going through a rehabilitation process. If we have got poor range of motion, that fundamentally places more stress on the muscle tendon unit. It therefore increases energy cost. It increases the likelihood of tissue damage. And so the net result is having an understanding of the range of motion is fundamental both in terms of performance and also in terms of rehab. So we know therefore it must be related to training and it's useful as a training response. Again, it is the most overlooked parameter, I would argue, in exercise physiology, that we assess an endurance runner and we might assess their VO2 max and their economy and their lactate responses. But fundamentally, they're almost meaningless unless we actually know that they've got a good range of motion. If you've got an endurance runner, which seems miles away from this as a topic, a good marathon runner, they could be, reasonably economical. But if they've got poor range of motion, say in the hip flexors, that's going to mean they use a greater oxygen cost. That means they're more likely to fatigue. So we need to be able to assess this. It's part of any athlete's makeup. I've used endurance as an example. It could be almost any sport, fundamentally, range of motion plays a part. We'll use it to identify weaknesses, both within an action or in relation to performance, and also this notion of injury. Now, the injury thing is quite interesting because there is this notion that poor flexibility increases the risk of injury. Now, there actually is very, very little evidence to suggest that that is the case. However, what we do know is if you've got excessively poor flexibility, then you are more likely to be injured. If you've just got poor flexibility, it's not considered to be a major contributor to injury. But if you've got very, very poor flexibility in, say, the hamstrings or the quads, as an example, very poor, you are more likely to get injury because you're putting more stress, as bullet point 1 is stating here, on the muscle tendon apparatus. And we've mentioned rehabilitation. Fundamentally, if I'm an strength conditioning coach or I'm a sport therapist, this is my primary measurement tool in terms of has the rehabilitation technique worked? It's your ability to quantify what is going on. If you are working with any patient group, you can't simply do it as a qualitative process. Yes, it feels better. Actually, yes, it feels better doesn't tell us whether there has been an adaptive response. Has the process worked? And having something to quantify that outcome is going to be very, very important to you.